So this is a featured article in interview with Dr. Thomas Emerson, MD, Urology, and also fellow of American College of Surgeons. He works out of Wellstar, Kennestone. And so, Dr. Emerson, how are you doing today?
I'm doing well, thank you.
Fabulous. So this article is actually titled Prostate Cancer or Prostate 101. So I'd really good like to cover the basics, inform our readers about prostate awareness, prostate cancer awareness. So if we would, let's just dive into the questions. Dr. Emerson, so if you would you kind of go over the basics of prostate, where the prostate is, and give us the basics of prostate?
Yeah, sure. So basically the prostate sits at the base of your bladder, your urinary bladder, which holds all your urine. And the tube that you urinate through, the urethra in a male, runs through the center of the prostate. Now, the prostate's function is primarily enzymatic. When you're young, it it functions for fertility. When a man has an ejaculation, the majority of that fluid is probably at least 50% from the prostate. There's an accessory gland that runs through the prostate called the seminal vesicles, and that probably represents about 48% of the fluid that comes out in an ejaculation. Only 2% of that fluid is actually sperm. So that sperm is not ready to fertilize an egg, and it has to travel through a fairly hostile environment in terms of pH level in the vagina, and then it has to swim all the way up and penetrate an egg. So I always like to describe for the patients who have infertility issues how that works. And the prostate fluid has an enzyme that will actually think of a sperm as having a helmet on it, and that has to be stripped off in order for it to penetrate the egg. And so that's part of what prostate enzymes do. And then it also buffers the ejaculate because, as I said, the the journey that the sperm has to take is a very acidic environment. And then the seminal vesicles produce a fluid that provide nutrients for the sperm so that it can make it through that journey to fertilize an egg. So it's primarily functions for fertility. As I jokingly say, after you get older, it's good for nothing. It can get infection, it gets enlargement, which restricts your urinary flow, and it can get cancer. And if the prostate were in a very easy place to remove it, we would remove it the first time it acted up, like an appendix or a gallbladder or tonsils. But it's in a very precarious place to do that without having a good reason, which would be.
Oh no. Did we freeze? Doc?
So you froze again there for a minute. I don't know how much of
Yeah.
that you got.
What about now? We good?
Yeah, we're good now. Did you hear all of that?
Yes, I did. Okay,
Okay.
now good question. Um here's another good question for you is actually for the average male, and I say average meaning that they have not had any genetic testing done. So at what age would you recommend for them to have their prostate checked?
So we actually have in different cancer organizations and the American Urologic Association, we all have guidelines. And there's pretty much a consensus that as a general rule, 50 to 55 is when we routinely start screening. However, uh,
Right.
there are exceptions to that. We usually recommend at least a baseline screening between 45 and 50 for most men without any risk factors. And if it's a good number, you can resume again beginning at age 50. In high risk patients, those being of African American ethnicity, people.
Oh no. Oh no. Gosh darn it. You there? Oh no.
PSAs at age 40.
I'm sorry, you froze again. You said African American males.
Okay,
And
so
now I use Starlink, so And hopefully it's not on my end. It's a satellite. I've got a satellite
Yeah,
connection.
yeah, yeah. So yeah, and I don't
Yeah, it's
know.
okay.
I've got plenty of dots, but anyway, so yeah, the high risk patients, those are African Americans, people who have a genetic predisposition, who've had a family member with cancer that got tested, and they got tested and are positive for BRCA2 genes.
Lulu, Lulu, are you using the internet?
Uh, yeah, you froze again.
Okay, I'm just making sure it's not on my end. I don't know, and I apologize for this connection here.
That's
Um,
okay. Let's see.
we were doing just fine. Gosh darn it, Doc.
Can you hear me now?
I can hear you now. All right, and
All righty.
I just actually switched my internet connection. I've got two connections here, but so I'm no longer on the high
I,
speed.
I just did that as well. So
Okay, good. Hopefully, no more interruptions. Can we start over, Doc, if you would, with the
yeah, sure.
at what age?
Okay, at what age? People with high risk for prostate cancer, and that would be African Americans, those who have a very strong family history of genetically linked cancers, and patients who actually have been tested for the genetics that predispose to
Mhm.
prostate cancers, should be tested at age 40.
Okay. From our first meeting, my appointment with you, and for a lot of readers, you don't know, but I was just diagnosed with prostate cancer. Um, so this has become near and dear to my heart, of course. But as you
Yes.
were inputting all the information, and you actually said to me, okay, ethnicity, you're black. And I was like, woohoo, finally I'm being recognized as being black. And your response was, no, not today. Don't want to be black today. You really want to be white. And then you showed me on the screen itself, and the variance, which astonishes, it amazes me, was a 40% difference in African American males with my makeup, essentially all the information that was input. So the probability of me having cancer, good and bad cancers, which to me is an oxymoron, of course, like, how do you have good cancer versus bad? But you explained that. Um, but it was as high as 62% versus if my ethnicity was white, being as low as I want to say 21%. I was amazed. So if you would speak about that, please, because you mentioned that ethnicity.
Yes, and again, statistical probabilities are just that. It's, as I always tell all of my patients, you could be 20%, 40%, 80%, but at the end of the day, that's based on statistics, and you're going to be either, it's a binary choice. You'll either have it or you won't have it. And so it's the statistical probability. A lot of people think PSA is a prostate cancer test, and when they have an elevation, they actually come into my office thinking they have cancer because their test went up. No, the only thing that goes up is your statistical probability that we will find cancer.
Ah,
And what we worry about now is the grade of the cancer, because we know that men who live into their 80s and beyond essentially at autopsy series, 100% have low-grade cancer. They didn't know it, they didn't die from it. But it's the high-grade cancers that we've had the impact on. If you don't find those early to cure, and you have enough decades of life left, you may not get all of those decades, because a high-grade cancer without a cure figures out how to outfox all of the things we have to slow it down and to try to eradicate it, and oftentimes will take your life.
Okay. And Doc, what is a normal or acceptable PSA?
So really, there are several different parameters. If you're looking at an absolute number,
Mhm.
uh, you'll see the normal is less than 4. I really don't like that being used, because it is abnormal if it's above 1 under the age of 50. And so oftentimes, if a patient has a PSA on record that is above what I consider normal for your age, I'll simply repeat it. We never use one number to make a decision. In fact, we like at least 3 on the curve to see what it's doing, unless you come out of the chute with a first number that's really, really high. We don't have the luxury of time. And that's where the fractionated or free PSA come in. Those are it's an isomer of the of PSA molecule or protein, and that is something that is the database that I showed you with the red dots and the yellow dots,
Yes.
and that just gives us a probability. Those are all people exactly like you that have already had a biopsy, and we know what kind of cancer they had, good, bad, or none.
Sure.
And so that's what really directs us to the next phase of the workup.
Okay. And Doc, is prostate cancer genetic? And if so, at what rate?
So only about 10% of patients who have prostate cancer have a gene that may be responsible for producing it or allowing those mutations to occur. Typically, if you have a strong family history of prostate cancer, or specifically BRCA2 cancers, which actually are prostate, colon, breast, ovarian, and pancreatic, when you go to a geneticist without having a diagnosis of cancer, and you tell them you have 7 relatives, first
Yeah.
degree relatives that have one of those cancers, they will definitely test you genetically. And the key to know your genetics, um, as I told you, it's not really about you right now. It's about your children and your siblings. If you test positive, then the recommendation would be your siblings and children would get tested, because especially with the children, if they test positive for a certain type of cancer, then you're going to do earlier and advanced screening for that particular cancer, because we can't prevent anyone from having cancer, but we can find it early enough
That's
to
right.
still cure it. And that's what the genetic testing at your age is for. It's really for your children. If you reach a point where you have such a bad cancer that everything we throw at it doesn't work, then you go to targeted therapy, which is based on your genetics.
Excellent. And so, how big of a role, because we've touched bases on this, how big of a role does age play, ancestry, ethnicity, the likelihood of
Well,
developing cancer?
age is important only in the fact that the earlier you find a prostate cancer, um, and when it's confined and is curable, you want to find the high grade cancers at an early age, because they typically occur at an earlier age. And those are the ones that unfortunately we don't find in time, or historically haven't found in time. We can still treat the disease. You won't die of the disease, necessarily in 5 years, but 10, 15, 20 years down the road is significant for a 50-year-old. You
Mhm.
want to get them, if they are going to live into, especially with a family history of, 80s and 90s, for parents and grandparents, you have a pretty good shot at making it to that age, um, as long as you don't get a cancer that's going to kill you before that.
Sure. So you know a little bit about my background that I moved up here from West Palm Beach a couple of years ago. I'd like to think or feel that I've led somewhat of a healthy life. But I moved up here to Georgia intentionally for to create a sustainable farm. I want to grow my own food. I want to raise my own food. Is there a such thing as maintaining good prostate health?
Yes, and we do talk about uh, diet related to that. And I always use the example of prostate cancer. If you look at different ethnicities and regions, the Japanese have about 1/10 of the incidence of prostate cancer as we do here in the US. But if you take young Japanese men and they move to the US and adopt our Western lifestyle, including our diet, the incidence of prostate cancer increases. Now, obviously, some of that is genetic as well, because in terms of ethnicity. If you look at risk of prostate cancer, it's African American, and then it's Caucasian, and then it's Hispanic, and then it's Asian, and so you keep going down risk factors, but diet can matter. And if you look at the diet in the Japanese culture, it's a lot of fish, it's a lot of soy protein, it's not any red meat or fat, not much dairy. They do a lot of soy. They do a lot of like I say, fish instead of red meat, rice.
Mm.
They do a lot of antioxidants. And so, as you know, we gave you some dietary guidelines related to prostate cancer,
Yes.
and it does help. So I think that reducing meat and animal fat certainly is key. Reducing dairy, and then really, I think the antioxidants are very important. It's like lycopenes, which are in tomatoes, and then you've got the isoflavones that are in soy and tofu and ground flaxseed, pomegranate. I gave a whole list of things that are actually good.
Right.
And quite frankly, people who have had their prostate removed and had a recurrence with very low PSA, sometimes we'll monitor those patients before we do secondary treatment. And you can actually look at the velocity of the PSA slow down when they get religious about doing some of those dietary restrictions.
Yeah.
So it's pretty impressive. So yes, diet has a big role.
Yeah, and I've became very religious when it comes to my health and actually what I my nutrition. Have been in the past,
Yeah.
but you actually told me something that more people die every year by drive-ins versus drive-bys, right? Remember telling me
Hmm.
that? Yeah.
Yeah.
So nutrition really important. And I've been somewhat paranoid. I'd like to say that, as far as what I eat, I'm more plant-based right now. Haven't had any meat since my first diagnosis. Yeah. So now,
Yeah. And
Mhm.
moving forward, that also is important. Hopefully you at least on paper you look like it's going to be totally confined in a curable disease. But sometimes prostate cancer just takes one cell that's already left the train station is somewhere else in your body. We can't detect that, but despite definitive treatment, 5 years, and it's not on, we see it not commonly, but anywhere from 5 to 15% of the time, somebody who had surgery, a completely negative margin, and 5 years later, their PSA becomes detectable again. So that was a cell that already escaped the prostate, and we could not have no way to detect that. But again, having definitive treatment adds significant longevity. If you have a bad enough cancer that's destined to take your life, having definitive treatment for the bulk of the cancer extends that survival significantly.
Good. Dr. Emerson, I'd really like to thank you for your time. And just in closing, I'd like to turn over to you and say, do you have a closing statement for our readers?
I'm sorry, say that you froze again, you broke up.
Yeah, I was just saying, thank you for your time. Very appreciative. And do you have a closing statement about prostate or prostate awareness for our readers?
Well, there's so much more as you found out from our talk to cover. I will say that we now have prostate cancer by the throat, and we're squeezing pretty hard. Since I went into private practice, PSA went into clinical use around 1988, which is about right when I came into practice. And over the course of the last 30 years, we've seen over a 50% reduction in the death rate from prostate cancer.
Wow.
It's pretty significant. And if you look at the African American population, it's probably closer to a 65% reduction because that's the group that gets the higher grade cancers. And if you find it early enough to cure it, then that's how we get the cures and we get the survival benefits. So that's significant.
Excellent. Well, let's just say that I would really appreciate your time in the future because I would like to have a follow-up to this. And as I mentioned to you earlier, we do this on a monthly basis as far as prostate cancer and prostate cancer awareness, same way we do breast cancer and breast cancer awareness. So, Dr. Emerson, thank you for your time. I'm going to turn off the recording at this time.